Yeah, please go ahead, doctor.
Okay.
Yeah, I could share your screen and go ahead.
Can you all see my screen now?
Yeah,
Okay.
it's fine. Please go ahead.
Okay, just hold on 1 second. Okay. Good evening, everyone. I'm Dr. Viswanath. I work in Singapore General Hospital as a consultant. I'm very honored to be given this opportunity to present my experience in rectal tumors under KREST. When I did my training in Hyderabad, we used to go to hear Kakarla Subbaraw's lectures in KREST. I still remember those. Now it's a great honor for me to present under his foundation. I'm also extremely thankful to Dr. Ishwar sir, who has been my inspiration and also my mentor for my radiology journey. Okay, without further delay, I would start my presentation. Okay, I have no disclosures or conflicts of interest in this presentation. My brief outline for today's talk would be first, anatomy of the rectum. And so basically radiology is like, if you understand and know your anatomy, almost 50% of your job is done. Then once you know what pathology you're looking at, the next 25% is almost done. Then if you look into imaging through the surgeon's eyes, what they want or what you need to tell them, then your job is almost done. So anatomy, if you know pathology plus surgeon's perspective, it's all combined, forms a basic of any radiology concept. So we would look into anatomy first, then why you need an MRI for rectal cancer. Then how do you do an MRI? Then we would try to stage it. And then what are the basic things you should look for and definitely include in your report. So this lecture would have more images and less theory. I think there are many good articles and there are various guidelines. So I will not confuse you with all putting together. So my lecture will basically be, if somebody throws you an rectal MRI, which you have never reported, and to have a basic idea of what you need to look for, and then so that you can start reporting. Okay, so to give you a brief introduction, rectal cancer is quite a common cancer worldwide, and histology-wise, adenocarcinoma is the most common type of cancer. There are also various other subtypes such as squamous cell and signet cell carcinomas, but these are rare. So all today's talk and the staging is based on adenocarcinomas. So what has changed recently or during the course of time? So total mesorectal excision has become the standard treatment of choice for rectal cancers because there's a significantly increased the 5-year survival rate for these tumors. Now there's also approach to go for preoperative chemoradiation to prevent local recurrences in cases of advanced tumors. But for early tumors, still surgery is the first choice. And our role is mainly to evaluate these tumors so that you decide the path where these patients want to go, whether they can go directly for surgery or they want to go for chemoradiation before you want to go for surgery. Okay, so let's look at anatomy. So as you all know, rectum forms a distal 15 centimeters of your bowel. This is quite unique compared to rest of the large bowel because some parts of the rectum are still within the peritoneum, whereas some parts are outside the peritoneum. And it also has a close relation with the anorectal junction, where the tumors and the pathology is entirely different. And commonly, the last 15 centimeters is divided equally into 3 parts. First 5 centimeters as high, and the next 5 as mid, and the next 5 as low. So how does it rectum look on an MR? So rectum is composed of few layers. The inner one is the mucosa, then the submucosa, then the muscularis mucosa, then there's a mesorectal fat. Commonly, sometimes we may be able to see all these layers on a high resolution T2 MRI, but not always. Sometimes because of the rectal gas, you may not be able to see the clear differentiation, but still you would be able to see the outer T2 weighted hypointense muscularis mucosa, which is a key in all staging, which we'll come back to later. So sometimes you'll see it as a 3 layers clearly. Sometimes you'll just have these 2 layers. Then the most important part is the mesorectal fascia. So surrounding this muscularis mucosa, you have the mesorectal fat. So surrounding the mesorectal fat, you have the fascia. The fascia is commonly thin layered. It may be just 1 or 2 layers, but on MR, we may usually see it as a thin hypointense line. Sometimes you may see some few gaps within that, which means that they're beyond your resolution. So do not mistake that for something abnormal. So anteriorly, this blends with the denonubular fascia, and posteriorly, it blends with the presacral fascia. Okay, so you can see the presacral fascia outlining here, and that's the mesorectal fat. So that's an anatomical diagram to show you what we are talking about. So that's a rectum, and you have the yellow one, which is a mesorectum, and then which is surrounding that, you have the mesorectal fascia. This is most important because all the surgery involves total excision of the mesorectal fat along with the mesorectal fascia. So this is a surgical plane which the surgeons are looking at. So you need to understand this concept properly so that you can give a better report. Then the muscularis mucosa of the rectum continues below as an internal sphincter. The mesorectal lateral to the mesorectal fascia, the fat which continues into the intersphincteric plane. And then you have the levator ani muscle, which continues and joins with the external sphincter muscle. So understanding this internal sphincter, then the intersphincteric space, and then the external sphincter, all these are important for your staging. So the same anatomy on an MR. So you can see the levator ani, and then which continues as an external sphincter. Then you have the internal sphincter muscle, which is basically a continuation of the muscularis mucosa of the rectum. Then in between these two, you have this thin layer of fat density, which is the intersphincteric plane. Then the other important landmark to look for is the peritoneal reflection. So that's where your peritoneum attaches to the rectum, which is usually seen as a very thin hypointense line, and it's better seen on a sagittal. It's usually seen at the level of the seminal vesicles on the sagittal image, and in a female, it's slightly variable. You may see it along adjacent to the body of the uterus. On an axial image, if you're lucky enough, you can see it as a nice thin hypointense line. But if you find it hard, you always scroll up and down, and you'll always recognize this structure easily. Okay, so next coming to the basic question, why do I need an MRI? So once the surgeon diagnoses rectal cancer, then he orders an MRI to decide whether the patient can go in directly for surgery or the patient needs a preoperative chemoradiation so that he gets a clear surgical margin and then he goes for surgery. So the arrow always follows this direction. So you can't do an MRI first and then ask the question, is there a rectal cancer? So we are not doing that job. Our job is to stage in a biopsy proven rectal cancer. This must be kept in mind always because there are many requests asking for, is there a rectal cancer? So that's not appropriate. Okay. So basically, any locally advanced tumors benefit from preoperative chemoradiation. Any stage, there are various guidelines. American guidelines are slightly different from the European guidelines, but in general, any advanced tumor which is more than T3C or T4 or with nodal staging, they benefit from preoperative chemoradiation because it significantly reduces the risk of local recurrence because it gives the surgeons a better surgical plane. Okay, so what is our role? So as with any other tumor, we describe the tumor location. What is the morphology of the tumor? Is there some abnormal morphology you can tell, like mucinous carcinomas, and then you try to stage the disease based on TNM staging. There are a few peculiar things to rectal cancers, what we need to look for. So one is extramural vascular invasion, which will come in detail later. Then you have to look for the relationship with the adjacent structures. There are unique structures in the rectum, which the sphincter complex in the anal canal, and you're looking for mesorectal fascia involvement. So we are going to decide whether this patient is going for surgery or neoadjuvant chemotherapy. So you are going to provide the surgeon a good surgical planning and then identify the poor prognostic factors of extramural vascular invasion. Is there mucin content and the mesorectal fascia involvement? The common causes for local recurrence are if the patient, they don't get a preoperative radiation therapy or chemoradiation, if the circumferential resection margin or commonly the mesorectal fascia involvement is there, if there is EMVI, or if the tumor is close proximity to the anal verge, if there is tumor perforation prior to surgery, or if there is anastomotic leak or dehiscence after the surgery, and obviously with higher TNM staging and lower tumor differentiation. Okay, so how do we do the MRI protocol? In our hospital, the MRI protocol for pre-rectal cancer staging, for staging of rectal cancers is standard. We don't alter it based on individual preferences. So it's either done in 1.5 or 3 Tesla MRI, and we do not administer any ball preparation or drugs, and there's no IV contrast for staging studies. So the basic sequences, what we do is, first we do a search haste for planning to identify the tumor. So most of the radiographers are well trained to identify where's the tumor. This is important because once I identify the tumor, so even if they don't identify it on the planning, the first sequence done is a SACH T2, and most of the radiographers would identify the tumor. This is important because once I identify the tumor, the coronal T2 is planned parallel to the lesion and your axial T2 is planned perpendicular to the lesion. This is also important to get a good study, because once you obtain a coronal T2, which is parallel, and axial T2, which is perpendicular to the tumor, not to the rectum, you get a good assessment of the mesorectal fascia, the mesorectal fat. So once you have a high resolution T2, high resolution means it's at least less than 3 millimeter thickness. You have T2 in all three planes, almost half of your job is done. Then we just obtain T1 fat set, and then diffusion is also a part of the standard protocol involving high B values, but we don't administer contrast. Contrast is useful only for reassessing the tumor after surgery, or if you're looking for any other non-rectal tumors like rectal wall lesions or perirectal lesions. So here you can see, so initially a SACH T2 has been performed. So you can identify the tumor here. So the radiographer goes and plans the axial with exactly perpendicular to the lesion, and you plan your coronal parallel to the lesion. So basically you get these three set of images: high resolution T2 with a sharp resolution, which is the most important part of your imaging. And then we obtain an axial FATSAT T1. This is sometimes useful to identify the lymph nodes, but non-FATSAT T2 is a key for your diagnosis. Then you have a high B value diffusion. Usually you can, based on individual preference, you can do a small FOV diffusion weighted images, which gives a better resolution, or you can do a large FOV diffusion based on a. So large FOV diffusion has got an advantage of you get a better assessment of the surrounding structures, you identify lymph nodes. So it's just based on personal preferences. So how does a rectal tumor appear? So first we saw the normal anatomy where the rectal wall was very thin. Here we have a very large tumor, which is very obvious to everyone, which is an intermediate signal intensity, and it would show marked diffusion restriction on diffusion weighted images, which means that it's bright on diffusion and dark on ADC maps. Whereas sometimes if the rectal tumor, not like the first case, it's just focal wall thickening, we may not be able to identify the entire tumor on T2. So that's where your diffusion really helps. Here you can see that the tumor is almost circumferential, and which is bright on diffusion and dark on ADC maps. Whereas here you would be thinking, is this intraluminal or is there a tumor there? So diffusion helps in these circumstances. So one important thing you should always remember, so compared with the previous, that was just intermediate T2 signal intensity. Here what you can see is a very, very high signal intensity, which means that this tumor has got more mucin, or it's a mucinous tumor. This is important to put it down in the report because these tumors have a very poor prognosis and high risk of local recurrence. And if you see on the diffusion, compared with the previous tumor, we saw that that was showing marked diffusion restriction, whereas here, if you see, it's only minimally bright on diffusion, and it's not dark on ADC maps. So this helps us to differentiate whether there is mucin content. So high T2 and not much of diffusion restriction are the key to identify mucinous tumors. Okay, so now let's come to staging. So the TNM staging is standard, which every where it's followed. So T0 is no primary tumor. So T1 involves your submucosa. T2 involves your muscularis propria. So can MR differentiate T1 or T2? It may not be possible. So our main role is to identify whether it's a T2 tumor or it's a T3 tumor. T3 means that it has invaded the muscularis propria and it has gone into your perirectal fat. The T3 tumor is further classified based on how much tumor has extended into the perirectal fat, just by measuring from the rectal wall. Is it less than 1, 1 to 5, 5 to 15, or more than 15? So basically, these two are combined, which means that anything less than 5 or it's more than 5. Then T4A involves the visceral peritoneum, whereas T4B involves directly the adjacent organs. So that's a pictorial representation. So that's your T1 tumor. You can see the muscularis propria is intact. T2, it's involved. T3AB, which extends, but it's less than 5 millimeter. Here, T3CD, which involves more than 5 millimeter into the mesorectal fat. So that's a mesorectal fascia, which we are talking about, and which we'll be talking about repeatedly, because that's one of the most important thing what we are looking at. And how far is the distance from the mesorectal fascia? Is it less than 1 millimeter or it's more than 1 millimeter? We'll come to that details a little later. Then we would have a T4A, which means that it involves a peritoneal reflection, and it's a T4B, it involves adjacent organs. Then you have the lymph node assessment. MRI does not provide much clarity on lymph node status, but the guideline is any nodes, regional lymph node involvement is N1 disease, whereas your non-regional lymph node involvement is M1 disease. So this has to be kept in mind. Okay, so why do we need to know so much? Because based on your tumor, the surgery, there are surgical differences. So let's say there's a small tumor here, and your outer muscularis is intact, your mesorectal fat is intact. These patients can benefit just from transanal surgery. But MR cannot definitely say whether it's a T1 or T2. So that's a standard surgery, surgical resection margin, which is low anterior section for any mid and upper rectal tumors. So this involves entire resection of the mesorectal fat along with a part of the sigmoid, and then you get a end-to-end anastomosis between your sigmoid and your anal canal. For low rectal tumors, even they do a ultra low anterior section, so not necessarily restricted to your upper rectum. So if the lower rectal tumor involves your sphincter, then you can no longer do an anterior resection. You will have to go for an abdominal perineal resection. Of course, that total mesorectum is excised, but you can't do a sphincter sparing surgery. So let's say sometimes the tumor just involves the internal sphincter, but your fat plane is preserved. Here, they may consider a abdominal perineal resection, but trying to spare at least the external sphincter. Okay, so let's see how it looks on MR. So this thing, always keep in mind, T1 or T2, we are not trying to differentiate it on MR, this differentiation can be done only with endorectal or transrectal ultrasound. And our aim is to differentiate basically between these two tumors. So here are sagittal and axial T2-weighted images where you can see, so that's an intraluminal intermediate signal intensity lesion, but you can see that's the outer wall. So you can see the hypointense muscularis mucosa, which is preserved. So which means that the tumor is not extended into the fat, and it would be a T1 or T2 tumor. So here it's a bit irregular, but still you can see that the T2 hypointensity is preserved and you don't have any tumor in your fat. So this is again a T2. So always make sure you look in all planes. So you had a good one here, and still you need the plane to be preserved in all the coronal and sagittal plane as well. Then one important thing is you may have slight speculations, which are commonly called as a desmoplastic reaction. This is just the reaction of the tumor and doesn't necessarily mean extension of the tumor. So these ones, you can still mention it in the report at there's mild fat stranding or desmoplastic reaction, but some people call it as early T3 image on staging. So you can see there are mild speculations, but as such, you don't have tumor signal intensity in these. So in these circumstances, your diffusion really helps. Is there really a tumor signal within these speculations? Okay, so compared to the previous one, here also we have a tumor, but you don't have the hypointense line. So, and also if you see the contour is lobulated or it is bulging out. So, which means that it's no longer a T2. This would be characterized as T3 on MRI. So once it's T3, you measure the tumor and do not include your speculations into the perirectal fat. So based on your measurement, you can still categorize as T3AB or T3CD. So just measure your distance from the rectal wall, how much is extended into the perirectal fat. So this one is a obvious T3CD, and it also involves the mesorectal fat and your fascia, so which will come to it a bit later. So for invasion of adjacent organs, the same criteria elsewhere in radiology holds true here. If you have just the loss of the fat plane and corresponding T2 signal abnormality on the organ, then you call it as definite invasion. Whereas if the fat plane is lost, but you don't have any corresponding T2 signal abnormality, you just label it as possible invasion. If the fat plane is completely preserved, you label it as no invasion. To show you for a few examples, so here you can see there's a rectal tumor here, and that's a prostate, but you don't have any fat between these two. And then you have, actually you can see that this prostate is bulging. So we would label this as possible invasion. So compared with the previous one, where you can see the tumor actually extends into the prostate and there's signal abnormality. So this would be definite invasion. So you can see more examples here. So that's like an extensive infiltrative mass. So you can see that's the uterus, and your tumor is almost encroaching and invaded the adjacent uterus. So that's another example to show the extensive invasion of the prostate. So next, what we'll look for is whether it's involved the peritoneum. So first we saw peritoneum as a thin line, whereas here you can see the peritoneal lining. You can see that's a tumor there, which extends all the way. And then you also have nodular extension on, which means that the peritoneal surface is involved. So this should always be included in your report. Next, coming to the important concept, the mesorectal fascia involvement. So as we saw, the peritoneum attaches to the rectum and the upper anteriorly. So which means that the mesorectal fascia is no longer there in your upper anterior and anterolateral tumors. So let's see how does it. So you have the peritoneal attachment to the rectum, almost at the mid rectum. So if you cut your rectum on the axial, you would see that this part of the peritoneum, this part of the rectum is outlined by peritoneum. So which means that if there is a tumor here, you do not comment about mesorectal fascia. Whereas in the middle rectum, it's the lateral surface still has mesorectal fat, whereas here it's completely surrounded by the mesorectal fat. You don't have any peritoneal lining in the lower rectum. Commonly, it's referred as mesorectal fat is involved, but still the surgical name or the surgical term used is circumferential resection margin. Some surgeons still prefer those, but if you put it down in the report that the mesorectal fascia is involved, that's sufficient. So they call, if it's a tumor extends all the way to the mesorectal fat, and the tumor distance between the tumor and the mesorectal fascia is less than 1 millimeter, it's called a positive CRM, or you can label it as mesorectal fascia involvement. If the distance between is between 1 to 2 millimeter, you call it as threatened. So here you can see, so that's your mesorectal fat, that's your mesorectal fascia. Here you can see tumor is extending anterolaterally, but you have a very nice margin between the tumor and the mesorectal fascia. So this would be, you label it as mesorectal fascia is not involved. Another example for non-involvement, you can see the tumor extends anteriorly, but the mesorectal fat and the fascia here, which is completely free of the tumor. Then here, you can see that there is gross tumor extension here. You have the mesorectal fascia, which is very close, and if you measure, it's less than 1 millimeter, and you call it involvement. Here, this is obvious involvement. You have the tumor signal all the way to the mesorectal fascia. Here, you won't have any doubt. But whenever you have tumors which is extending all the way, you always measure the distance to call it whether the circumferential resection margin is free or it's involved by the tumor. So you always report the minimum distance to the mesorectal fat, and make sure you do not include your haziness of the perirectal fat as a guide for your measurement. So if the tumor is in the peritoneal portion of the rectum, you can label it as the mesorectal fat involvement is not applicable in these tumors. Okay, so another important concept which is not described in TNM staging is EMVI, which means that extramural vascular invasion. Why is it important? Because as a standalone factor, this is an indicator for poor prognosis, and they have higher chance of local recurrence and distant metastasis, and these patients respond very poorly to neoadjuvant chemotherapy. So there are various grading scale available, but let's not go into those details. So basically, we are looking for extramural vascular invasion in any T3 tumor. So T2 tumor would be negative. So if there is contour irregularity, but you don't have any vessels adjacent to it, the vessels are all on this side, then you can be sure that it's negative. If there are vessels, but the vessels seem just linear and are not nodular, you can still call it negative. But if you see frank extension into the vessel or nodularities which extend along the vessel, you call it as positive for EMVI. So let's see a few examples. So here you can see a few speculations, but we can't be so sure whether it's involved. So if you contiguously see the few slices, you can see that all these are nodular, which extends along the vessels. So then we would label it as EMVA positive. So a few more examples to show. Here you can see all these tumors extend along the vessels. That's a basic tumor there, and that's a sagittal section, which so mostly sagittal sections give a better idea because you can see the extension along the vessels. So here you can see, so that's a gross infiltrating mass. You can see that's our vessels there, and you can see all these are tumor tissue surrounding these vessels, and this would be an EMVA positive tumor. So most of these patients would already had liver metastasis at the time of presentation or prone for developing liver metastasis. So I'm showing a few examples so that you would recognize these when you see it in your reporting next time. So here you can see there's bilateral extension of soft tissue along the vessels, which is better demonstrated, and it's more bulkier on the left side. Okay, so coming to lower rectal tumors. So lower rectal tumors, you need to have an additional reporting of the sphincter involvement. So here you can see, so that's a rectum. This is a normal scan. So you can see, so the rectal mucosa becomes a muscularis mucosa becomes an internal sphincter. Then you have the levator ani. Then that's your puborectalis and the external sphincter complex. Here you can see a nice fat plane which is dividing the internal and your external sphincter. So you look for these normal structures in all patients. So compared with that, here you can see, so that's a tumor, it's a lower rectal tumor. You can see that this signal extends all the way to your internal sphincter. And then that's the levator ani. The levator ani is involved, the intersphincteric plane is involved, and also your external sphincter is involved. There's also a grading staging based on what is involved. Let's not go into that depth, but you need to remember, you look for your internal, your external, your fat plane, the intersphincteric fat plane, and also the levator ani muscle. You describe each and every one separately, which is involved or it's preserved. Okay, next coming to nodal staging. So traditionally, nodal staging, we are not always good at that because we rely most on size criteria, and various studies have got various size limits. So, but still, it's not a reliable criteria. But what we need to remember is that any loco-regional node enlargement or involvement is considered just a nodal disease. If there are enlarged lymph nodes outside your loco-regional involvement, which means that it's already an M1 disease. So the mesorectal, the superior middle and the inferior rectal, sigmoid mesentery, inferior mesenteric, the lateral and the presacral, the internal iliac, all are considered to be loco-regional lymph nodes. Whereas any lymph node in the pelvic side wall, external iliac, common iliac, retroperitoneal, or inguinal lymph nodes are considered M1 disease. Some categorize the inguinal as loco-regional, some categorize as M1 disease. But let's see how to evaluate these. So even normally you can have mesorectal lymph nodes. So any lymph node, any mesorectal lymph node, which is more than 9 millimeter, is considered positive. But if they are less than 9 millimeter, so radiologists basically rely on size criteria most of the times. But if the size is smaller, you look for suspicious features, which are any irregular border of the tumor, or if any irregular border of the lymph node, or if the lymph node has got mixed reticular intensity, or if the lymph node is like rounded in shape. So this is a criteria for mesorectal lymph node. For lateral lymph nodes, there are also again very different criteria. Some considers any size of 7 millimeter to be considered abnormal, but some still follow the same criteria for the mesorectal lymph node assessment. Okay, so that's your mesorectal fat and the fascia, which we talked about. And you can see it's a very heterogeneous signal intensity. Though the size is small, the heterogeneous signal intensity favors a metastatic lymph node. Apart from that, what you're looking at is there are also lymph nodes outside your mesorectal fat on either side. So this needs to be reported because this is not included in your surgical plan of resection. So any tumor which is lateral to your mesorectal fat should be included in your report, and including the size. So you can see all these are more than 7 millimeter, and these are all positive lymph nodes. So you can also have multiple prominent lymph nodes in the perirectal region, and MR cannot really differentiate which of these is tumor and which of this is normal lymph nodes. So here again, few examples. You can see it's lateral to your mesorectal fat, and you can see these are all heterogeneous. If you carefully observe, they're all irregular. So these are all suspicious lymph nodes. Here, obviously, these are all very large. So you won't have any doubt in these to call it as suspicious, but the smaller ones, we may or may not be right most of the times. Here you can see it's a small lymph node, but you can see it's very dark, it is irregular. So this would be considered suspicious lymph nodes. So whenever a lymph node is located close to your mesorectal fat, do indicate that separately in your report, saying that there's a large lymph node and so distance from your mesorectal fascia. It's not considered involvement, but it's considered to be a important for their surgical planning. Here you can see it's almost an infiltrating mass here, but sometimes it's very hard to differentiate whether it's a lymph node or an extramural extension of the tumor. So if you scroll contiguously, you would be able to make out so this was a large extramural extension, and do not confuse it for just an isolated lymph node. So we have seen most of what to report on the preoperative staging. And if you have any of these factors, like your circumferential resection margin is involved, or it's a tumor which extends to involve the spinsters, or if there's peritoneal involvement, which we saw, all these indicate that these cases are more prone for local recurrence. So we have diagnosed the patient has gone for chemoradiation. Then, so this treatment response evaluation itself is a separate topic, but I'll touch it briefly so that in few slides, a few minutes. So normally what happens, so once they give a chemoradiation, the tumor signal disappears and the tumors can undergo fibrosis. So if if there is dense fibrosis and you don't have any tumor signal, then you consider it as a complete or near complete response. But after chemoradiation, if you don't have any change in the signal intensity or the size of the tumor, you can consider it as no response. Then intermediate response is based on how much of tumor has gone away and how much as fibrosis has set in, or sometimes even after treatment response, you can have mucinous change in the tumor, which is considered a normal response. So you are basically looking for, is there, how much of tumor signal is there, how much of fibrosis is there, how much has gone for mucinous change, and how much of residual tumor is left. So based on all this, whichever predominates, you give a scoring based on is the complete response or a moderate response or there is no response. So I'll just show you a few examples. So here you can see, so that's a large tumor. It has extended all the way to the lower rectum. It has involved the internal sphincters. So this patient went for chemoradiation. So you can see there's a significant reduction in your tumor signal, and you can see even the internal sphincters have their normal appearance of low signal intensity changes. Even here you can see there's extratumoral or lymph node deposit, and you can see it's almost near or complete response to chemoradiation. The same case in an axial images. Here you can see multiple tumor metastatic lymph node deposits, and all these have disappeared. So any reduction in size of the lymph node is considered to be a good response. Here you can see the peritoneal extension into the mesorectal fat, and after radiation, you can see just some residual linear signal intensity, which indicates a treatment response. So here diffusion and contrast always helps to assessment of the any residual tumor. So here you can see that's a pre-image. You can see the tumor restriction here, and you can see that it's almost or completely resolved here, and you don't have any residual tumor in this case. Whereas here, this is another case. You can see, so that's a tumor which is eccentric on just the one wall. But here, after radiation, you can see that it's entirely dark, which means that it's T2 hypo, and this indicates fibrosis of the tumor. Sometimes contrast helps to look for any residual tumor left. So that's a chemoradiotherapy. That's bulky tumor there. After radiotherapy, chemo-RT, the tumor is almost completely gone, but you can identify some focal enhancement in the anterior wall, which is a residual tumor. So contrast helps only in the post-treatment evaluation, not for pre-evaluation. Okay, coming to the last stage, how do I put the report? Okay, so let's take a look at this example. So we don't have a live audience, so I will not put it as a question, but you can see there's a quite circumscribed tumor here. But this is slightly different from what we saw before. The difference is that this is entirely within the wall of the tumor, or which means that it's entirely within the muscularis mucosa, and it's bulging out. So this one is a rectal cyst. Sometimes you may be faced with these circumstances, which means that you don't have a pre-operative, pre-histological diagnosis before the patient comes for MRI. So do not get fooled by these saying that they found something on rectal examination and then referred for MRI to rule out a tumor. And our job is not to rule out a tumor. Our job is to stage the tumor. Okay. So this was, so let's say we have found this case. So we saw a rectal tumor. So what's the first step to do? So here, first identify normal anatomy. So that's your peritoneal reflection. Next, you go for distance to the peritoneal reflection, where the tumor is located. You can see that tumor is well below the peritoneal reflection. So you can give this measurement that the tumor extends, the upper edge of the tumor is well below the peritoneal reflection, and so on, so centimeters. Next, what we need to do, the lower edge of the tumor to your anal verge. Then your lower edge of the tumor to the anal canal. So both these measurements has to be given. So a curved measurement is better preferred in these because rectum is a anorectal junction or curved structures. So give a curved measurement of the lower edge of the tumor to your anal verge, and also lower edge of the tumor to the anal canal. And next, give the craniocaudal length of the tumor. So next step, give the circumference of the tumor. So it's better described in a clockwise position from maybe 5 o'clock to 1 o'clock in this case, or some people prefer to give it as a antro or right anterolateral wall, but the clock face is preferred. So almost half of your report is done just by these 5 measurements. So where it's a circumferential tumor, then you look for the clock phase, then you look for the signal intensity. Is there any mucin content here? I don't find any here. Put that in the report. There is no mucinous change. Then location of the tumor, where it's in the low, mid, or the high based on the distance from the anal verge. Also measure from the anal sphincter. Then give the craniocaudal extent of the tumor. So almost most of all your measurements is done. Then whatever we saw, T staging, N staging, and then don't forget your circumferential resection margin, and then measure the minimum distance from your tumor deposit to your mesorectal fascia. If the tumor is in the upper, look for anterior peritoneal reflection. If the tumor is located below, look for internal and external sphincter involvement. Then look for extramural depth of invasion and give them the size, and always comment about EMVI. So once we have all this and you're looking for any additional finding, almost your job is done. Okay, so coming to the last few slides. So you can get more information about, so there are various guidelines. So one is basically from US, which you can find in the SAR, or the Society of Abdominal Radiology website. They have multiple disease-focused panels. In that you can find rectal cancer. They even have a staging template. So we prefer to use staging template so that consistency is maintained for the next reader. And also there are European guidelines and European consensus statement for rectal cancer imaging. So coming to the final slides. So what have we learned today? So basically, if you understand and take home these points, I would be happy that I have done my job well. So you don't need any bowel preparation before you need a rectal MRI. And a good high resolution T2 is sufficient for a diagnosis with the supplementation of diffusion weighted images for preoperative pre-chemo RT evaluation. And you try to perform staging only for biopsy proven cases. Do not go and jump saying that I found a rectal mass and this one would be a rectal stage so and so if you don't have histological things. And then differentiation between T2 and T3 tumors is crucial. Always look for mesorectal fascia involvement, which means that the circumferential resection margin is involved, and which basically doesn't have a margin for the surgeons. For low anal tumors, always report whether the sphincters are involved and look for EMVI. I think I've done a brief overview of what to look for, and I would conclude with this slide, and I'm happy to take any questions.
Thank you, Dr. Viswanath. Thank you very much for your presentation. Actually, it's an excellent one, and it covered the entire gamut of imaging rectal cancer. Dr. Ishwar.
Yeah. Thank you, Viswanath. That was a fantastic overview for a general radiologist like us. You've taken us really handheld us to report MR of the rectum for staging as well as post-treatment response and various local extensions. A couple of questions before I hand it over to Dr. Jagan and others who have much more wider experience in that. Bowel preparation, you said no. Is there any role for instilling saline or water into the rectum distended before you do that? That's one. Second question is diffusion weighted imaging in terms of characterizing lymph nodes. Does it help apart from the various criteria you said of size and irregularity and signal and heterogeneity? And then do you always perform liver imaging? Do you extend the study for liver evaluation when you do a pelvic MR for rectal staging, or is it the role do you look for a PET CT to do that? And mucin, the last question is about mucin. Mucin tumors can be diagnosed in histopathology as well. I know it's good to report on MR as well to characterize them, but does it always help in telling about mucin, where histology would be saying that? Over to you, Viswanath.
Okay. So let me answer. For mucin, the main problem in pathology is sampling error. So if they have not sampled, because not entirely the entire tumor may not be mucinous content. So if they have a sampling error, and if the tumor is very large, only half of it can be mucinous change. So it would be always better for us to report that. Okay, so coming to the next question, diffusion, does it help in lymph node assessment? It does help for you to visualize the lymph nodes, but to call it whether it's a metastatic lymph node, it may not be of much help. But when you do a pre-chemo and post-chemo, the reduction